Hello, everyone. Welcome back to the podcast for 2025 with Bo and Shaun. Bo, today's topic is one that I think we've spoken about in various ways in the past, but we're going to frame it up a little bit differently today. And I think this will be useful for a lot of practitioners, particularly those dealing with uh, pain-based presentations. And that is why the narrative matters. What impact do you have on your patient's story? The words we use, the story the patient creates, and the words that we use to influence that in our interactions with the patient. Where do you want to start with this one, Bo?
Yeah, well, it is so important because when we actually listen to our patients, we understand what they believe about that story, and that story becomes who they are. It's like saying, "Hi, my name's Bill. I've got two kids, two bulging discs, and a dog named Spot." And that is so much embedded in their story, and they become the patient. They're a patient as opposed to a person, and that is so stuck in their beliefs about their body, how they interact and engage with the environment that influences their emotions and their behaviors. And so it becomes so ingrained in who they are as a person, and it's really difficult to move beyond that when that's really what they believe about the structural integrity of their body, and that shouldn't be the focus, especially the narrative that we tell our patients as clinicians, and the narrative that the patient walks away from your clinic room should not be so much focused on that structure.
It's interesting, isn't it? The human brain, I've said this before and other people have used this phrase, but the human brain is a meaning-making machine. It will develop a story, a narrative, the term we're using today, around what something means to us. When somebody lifts something and they feel a pop or a crack or a click or something kind of, there's some audible or palpable sort of sensation in their body, they'll feel like something has shifted or moved, and that plays into this understanding or belief around a structural problem. And then if pain is associated with that, then of course they're going to think, well, there's a structural change equal pain, therefore my pain is as a result of that. But we know that pain is complex and can be from various different things. And so this meaning that we'll create in our minds as the patient experiencing something becomes the reality for us. And not only does it become the reality, it perpetuates the experience. Because if we believe something to be true, our brain will rewire itself to prove that to be the case a lot of the time too. And so we get these neuroplastic changes as a result of the beliefs that we have. And so our job as a health practitioner is obviously to not just to influence that, but the first step should be to understand what meaning the patient has created, what narrative they have created around their pain, around their clinical presentation, so that we can first understand where they're coming from and what beliefs they hold, so that we can either reinforce that if it's correct, hopefully, or provide a different narrative, a different story to sort of reset that thinking and to maybe steer them in a more hopeful, positive, optimistic direction.
Yeah, and pain is embodied. We can't separate the body from the brain. These things coexist, and the same goes with our emotions and our attentional focus. If someone is focusing on a particular area, that will create more importance of that area. It will create neurobiological changes. So we'll have a number of changes in our system that can influence the level of threat and the response that's associated with that threat. And even if you're sitting or standing, wherever you are, you can direct your attention to a particular area and you'll start to experience more sensations around that area. So if you're sitting, you might start to direct your attention towards your foot and just sit with that for a moment, and you'll start to notice more sensations in your foot that you hadn't experienced before. You can shift your attention to your shoulder, and again, you'll start to notice more sensations. You might feel the skin, you might feel pulsing sensations. You might start to notice the shirt pressing against your skin. And so when a patient is constantly directing their attention towards damage, structure, pain, that is sort of the narrative and the story that they're telling themselves. There is increased attention so that the body is in more of this protected state. All right. And so, as I said, the pain being embodied, it's this combination of emotions, physical sensations, beliefs, and how we interact with that environment. And so I think if we as clinicians are constantly directing the attention towards someone's structure. For example, someone that's, and I've had this quite a lot recently where people are saying, well, I've got a patient and the disc isn't healing. Well, that's probably not a helpful thing to focus on the disc, because the body is incredibly adaptive. Do we actually need structure to heal? All right, because if it was always about perfect structure, then we wouldn't see numerous studies, overwhelming abundance of evidence, high level, high performance athletes that have structural changes. And this is across the general population as well. But when you look at high level athletes, for example, that have structural changes, that have pathological changes, that have completely no symptoms. Now, if we constantly directed their attention towards their structure and that's potentially fragile, there could be an increased risk of injury. Be careful, be mindful, don't avoid certain things. Think about how that attentional change would influence their neurobiological aspects. They might have increased attention that could lead to some avoidance behaviors. It could increase heightened levels of anxiety and fear and worry and concern about that area. And so you can see how that can influence our emotions and how we interact with the world. That also triggers neurobiological changes to go with that. And so while the structure may not really be the problem, it's what we believe about that structure. And so rather than focusing on the structure, is sort of like focusing on the pain, or the injury is like focusing on the past. All right. Will that be helpful in moving forward? Or could we shift that attention towards optimistic outcomes, positivity, goal-directed behaviors about where that person wants to be, and how they foresee the future? I think that can be an important way to shift that focus away from structure, from damage, from the pessimistic attitudes that may be associated with that, towards the future and more optimism.
Oh, I can see you're so passionate about this. It's oozing out of you. I think this is the perfect topic for us to discuss today. This is a great one.
Yeah,
Look,
and I love it because I see this so much in clinical practice, and really when they come in, it's so much about reframing it. All right, you can acknowledge what they're presenting with, you can acknowledge their beliefs, you can demonstrate that empathy for them, but and not dismissing it, but saying, okay, where do you want to go? Where do you see yourself in the future? And what's stopping you from getting there? And how can we actually get you towards things that you enjoy? Because as soon as they've got that optimistic attitude, and hey, there is a chance that I could improve from this, reinforcing positive beliefs, and reframing that can be so helpful. And you see that patients light up immediately, and so what are you talking about? I can go back to lifting weights. I've been told that I shouldn't do that, or I can play tennis. And it's really positive and really empowering for them. And again, it comes back to the thoughts and behaviors and their beliefs, right? If we can reframe that it's not necessarily damaged, that there may be some adaptations that have occurred. All right. And that's a fairly neutral word as well, that adaptations, and we can create positive adaptations. There might be some sensitivity, but there's also other contributing factors to this. All right. We know pain is so complex. If we just focus on one factor, it can potentially be harmful.
definitely. And this reframing of terms and words, I think, is probably more powerful than most people give it credit. And an analogy you could use would be like you could look at a knife, right? A knife can be a deadly weapon. The same knife could be used to make an amazing meal that could satisfy you and your family. It's the same tool, right? And how you look at it, it is the same thing. Somebody can have back pain, but how they view that back pain can be something that will help them stuck in the past or an opportunity for change. And I use this phrase quite a lot in courses, and I think a lot of people heard me say this before, but you'll have a patient that comes to you that says, I have a bad back, or I am in pain. And when someone says I'm in pain, it's like they're in a hole. They're stuck in it, right? They are one and the same with this thing. And if you can change that word, the simple shift from changing the word from pain to sensitivity, so you can say, "Oh, I understand. So your back's a bit more sensitive at the moment." And they'll say, and of course, the correct answer to that is yes, they are more sensitive at the moment. And then you could start to tease that out a little bit and say to them, "So are there days when your back, this issue with your back is better and worse?" And they'll say, "Yes, some days it's better, some days it's worse." Okay, so at the moment you're in one of the days when it's worse. Yes. So today's more sensitive than it is at other times. Yes. And that subtle shift from I'm in pain to it's more sensitive at the moment implies that there's a transitional period where it can get better, it can get worse. So there's already an opportunity for optimism there, an opportunity for hope. And we all know that the research is more optimistic and hope, well, then the more positive outcomes you get from therapeutic interventions and relationships and all those sort of things. So just making these subtle shifts and then getting the patient to understand that what you're saying is essentially the same thing that they're thinking, but with new words, but then pulling on that thread and seeing how far you can take it. Like, okay, so it's more sensitive at the moment. What sort of things typically make it more sensitive? And keep using those words to embed this new kind of fingerprint of language on them. And they go, yeah, it's probably more sensitive when I do this, this, and this. Okay, what sort of things make it less sensitive? Let's focus on that. Because if all you look at are the triggers, the symptoms, the triggers for symptoms, the patient becomes hypervigilant of those triggers. So establish that as a baseline and then immediately go into, so what kind of things make your back less sensitive? And they'll go, oh, when I, walk the dog or when I go swimming or when I do whatever. Great. Okay. So when in your week are you doing those things? How can we implement more of those things? Let's look for opportunities to reduce the sensitivity because at the moment your back is not broken. It's not, there's nothing structurally wrong with it. It's more sensitive. It's like the alarm system on your house turned up to 9.5 when it should be set at 2, right? Just like your elbow. And they'll go, what do you mean? Are you thinking about your elbow right now? Is it bothering you? No. Okay. So it's set at 2. It's where it should be. Like the rest of your body that's not giving you alarm bells at the moment. It's just a sensitivity dial. This is a neurological system that's giving you this information, not a structural problem. You've got muscles and joints and bones that are receiving information or perceiving information that's incorrect at the moment. Okay. Now, if you fell off the back of if you fell off your roof yesterday and you come to me with back pain today, different story. But you've had this back pain for 9 months, 6 years, 23 decades, whatever it is. So if there was real threat, real immediate danger from an acute injury, we'd be having a different conversation. Because that's not the case, there's a lot more opportunity for change here. And it's just a sensitivity dial that we're adjusting. And they're like, oh, right, different way of looking at it. Versus, okay, you've got back pain. I want you to go home and take a pain diary. Now, the pain diary is going to have you focusing on the days where you are, let's just say 6 or above on the pain scale out of 10. Each of those days, I want you to write that down in this diary and come back to me. We're going to look for some patterns in here. What does the patient do? They go home and they shrink their world to their back. That attentional focus increases and targets, puts a little red dot right on their low back, and all they're thinking about is when is their pain the worst? I guarantee you that pain diary will increase the intensity and frequency of their pain because they're looking for it now. And your reticular activating system in your brain finds the things you're looking for. So if you're looking for back pain, it'll happen more often. And so things like pain diaries are an outdated idea, I think. We can use the history of pain progression to give us an understanding of what's going on. But if we focus on that, then that becomes an amplification. It becomes a microphone for your pain.
Yeah, I probably would have a little bit different viewpoint on that. Um, it probably depends on how you do the pain diary. I think if we're looking for what may precede that pain and the consequence and the behavior that goes with that pain, and because that can give us an indication and help to reframe the story for the patient as well. And so you might look at that and say, all right, so when that pain was at a sort of 8 out of 10, you might get them to also to jot down the emotions and other factors that go with that. And it could be that they were at a really heightened level of stress at that point in time, and that influenced a higher sensitivity of their pain. And then looking at the consequence of their behavior related to that pain and how that influenced their ability to cope, because there will always be some form of trigger that influences a behavior, and there will always be a consequence as a response to that behavior. And so it's really about looking at behavioral change when we think about pain. And so if we can start to get our patient to identify, okay, well, yeah, I am starting to notice that when I'm in a certain environment, my pain is a little bit worse, or when I'm really stressed out, my pain does tend to go up. But when I exercise or do something that I enjoy, I do notice that my pain is a little bit better for a while. And so we can start to use that to influence behavioral change, because it's really hard, to tell a patient that this is what's causing it or this is most likely until we actually start to get them involved in that experience. Um, yeah, I think you're sort of right there, Shaun, where if we just focus on specifically the pain and jot down every time you've got pain, they will increase that attention. Oh, it is always quite painful. But what is actually contributing to that? Because it's when we can start to identify those contributors, we can create interventions for those contributing factors, or we can create interventions to address the consequence to that behavior. So they've got better coping strategies for when that behavior does occur. And so when we're looking at pain, if a patient has a good strategy to be able to manage that and identify, oh, okay, I did have a really bad sleep, I've been eating terrible food. Um, I can understand that might be contributing to why my pain is a little bit worse. So what I've got to do is to get back on track with my sleeping. How can I do that? Well, I know that good exercise, some meditation, some mindfulness, that can help to decrease my stress and improve my sleep. And so reframing it like that, then a patient goes, okay, so it's less about that my disc has gone out again, and it's more about the emotional, the psychological effects that may also increase the muscle tension that goes with that. So it's not that the physical is completely irrelevant, but by giving the patient those tools, then they can understand and see how they can manage certain things, and create a little bit better backup plan, rather than, where, oh, my pain comes on, they go into negative coping strategies, very passive, very avoidant. And that can actually have negative consequences in the long term. It might have positive consequences short term, where they go, oh, I just relax, to sit on the lounge, have a couple of beers or a couple of wines. Well, yeah, I mean, maybe in the short term that could be helpful, but in the long term, that's not a positive coping strategy.
Yeah, good. I like the way you framed that up. So I completely agree. If you have somebody focus just on the pain, that will increase the attentional awareness and the intensity of the pain, probably. But to your point, where you've expanded that and gone, okay, let's look at the trajectory of each day, I guess. If you're going to give someone as a tool a journal or a diary to track their experience, I would say to them, don't write down every day that you have pain. I want you to write down your experience of each day. So as a reflective piece, you might at the end of the day, how did you feel today in your body? What was your emotional state like? What was the stress levels like? What were the inputs? Did you exercise? Did you sleep well? All of those things. And then as a component of all of that tracking, you would comment on the level of or sensitivity of your back. And then you, the practitioner, can look at that and go, right, now we're looking for patterns. But if all the patient does is just track the days that they have pain as a way to see if they're improving or getting worse, then it will most likely just get worse. That's probably what's going to happen. But I like the expanded view of that. That's a good way of doing it. It gives you a lot more information because, like we said before, pain is multifactorial. And there are so many potential contributing factors to not just pain, but also coping mechanisms. And like you said, the triggers for the pain experience that they might be having or the sensitivity they're having. So yeah, good expansion of the concept.
Yeah, and that journaling, great, because it allows a patient to engage a little bit better and be more aware of their environment, and those contributors and contextual factors. When we think about pain, it is so much about context, all right, and that all really starts to link back together. And so, doing things like that, it can have neurobiological effects as far as decreasing stress and changes in the HPA axis and a number of different things that go with that. But, teaching patients to be more mindful of an area is powerful, because what you'll often find with people who have persistent pain is their pain vocabulary or their ability to differentiate painful from non-painful is very limited. And so you might look at, if they're focusing on their back, well, what other things can you notice around your back? So not so much the pain, but what other things are you noticing? And can you notice the skin? Can you shift that attention to somewhere else? And so that allows them to be a little bit more, I guess, have more cognitive flexibility. And I think that's really important because if we change our attention on an area, you can change pain very quickly, and you can demonstrate that to a patient in clinical practice, and using those attentional shifts that I spoke about earlier. And that can then help to rewrite their narrative. So if you can do that very, very simply and very quickly here, can you see how that might be a helpful intervention in the long term? And this is really hard. It's harder than it sounds because it does take a lot of practice, um, to be able to do some form of meditation. Our brain runs off and does all other things, and that's completely okay. It's about recognizing that and bringing it back and being able to shift and change that attention. But it takes practice, and I guess my point here is that a patient can do this themselves, and that allows them to improve their own self-efficacy. But it shifts that treatment approach from I need someone else to do this for me. I need someone else to press on a spot. I need someone to mobilize, manipulate, needle. Whereas they can manage these symptoms themselves, and it will create, neurophysiological changes. And I think that's really important, and it can be quite empowering for a patient to know that they've got the tools to do it. And I guess on the other side of that, if a patient is very much embedded in the structure, well, that won't work for them because they'll go, well, it needs surgery, it needs an injection. Exercise won't work because it's already fragile and vulnerable. So why would anything like any physical therapy or anything like that help? Why would any psychological focus or mindfulness help? Because there's a structural problem. And so what we really need to do is acknowledge that there may be some adaptive changes that have occurred, and that may be one contributor. But let's focus on things that we can control. Because, when we look at back pain, for example, even pathology of the back, there's actually more contributors to sedentary lifestyle, genetic factors than actual, structural problems. And and so if you think about, well, could we change the amount of movement that you do? Could we change help to influence your emotions by focusing on things that you enjoy a little bit more and addressing these other factors rather than just the structure? Because the structure is not a very reliable measure of whether someone is going to have pain or the pain will get better. Like even having an MRI, let's say someone has an MRI at early onset of pain and an acute pain, imaging them later on in 3 months, 6 months down the track is not a reliable indicator of whether or not their pain is still there or not. People can still have the same structural changes but have no pain, or they can have complete changes of the structure and still have immense pain. All right. And so that's the importance of shifting that attention away from the structure and focusing on other more modifiable factors.
Yeah, and that's a good point you raised there about, the structure can change or not change and they can still have pain. And as a manual therapist, we were all taught, most of us were taught in a very traditional kind of understanding of manual therapy, which is mechanistic. It's like you push on this, it moves it here, and that changes the outcome for the patient. And so I think, as professions, have probably perpetuated a lot of these incorrect narratives in the way that we will frame things up for our patients, because they'll come to us and say, "Oh, I just need a little bit of a touch up to to sort of settle my back down, or I need you to rub out my whatever it is to settle down this pain or that point, or flush it out, flush out the legs so I can get back to training. Like these are all mechanical kind of processes that we have say, just come in, I'll straighten you out before your event this weekend. It's like we're doing something that will change their body to put it in a better position. And they walk out and they go, wow, that was great. I feel better. Therefore, that story is correct, right? But what are we actually doing? We're changing we're providing new sensory information, which produces a different experience in this thing, not the other bit in the head, not the body. And so we perceive that the massage, the manipulation, the needle, whatever the tool is, has somehow released, adjusted, fixed, moved, cracked, popped, stretched, lengthened, shortened, whatever the tissue. And then that, as a result, for the patient, has changed the experience of their body for them. When in actual fact, that's not it. Like, we harp on about this in almost all of our episodes that, you're not fixing something, you're not putting something back in place. You are changing the sensory experience of the patient's body. And to your point before about, yeah, that can happen with a good night's sleep. That can happen with meditation. That can happen with watching a comedy on TV and having a bit of a laugh. That can happen with, a nice night out with your partner, walking the dog, a nice, like a good meal, a hot bath. All of these things make us feel better. And we don't probably put enough weight in that because that's not prescriptive. It's not medical. It's not technical. There's no process to it, and it's hard to charge for. So, you know, there's so many people in chronic pain out there that go and see a psychologist rather than a physiotherapist or a massage therapist or whatever. They'll see a psychologist. The psychologist does not lay a finger on them, but a lot of people in chronic pain have been helped by a psychologist. So that tells us that words matter, the story matters, the narrative matters, what we are helping our patients to believe or cease believing can have a huge impact on their experience. And it's why multimodal care is so important. Now, it's very easy to listen to us go on about this and say, well, what's the point of doing manual therapy? What's the point of physical therapy in any kind of form? Why bother if you can just give someone a warm bath and a nice hug and they feel better? Well, because there are efficient ways of making change quickly, and manual therapy is one of those. And then there are self-coping mechanisms that the patient can do as well. And so when we combine a manual therapy intervention, which gives the patient a period of time where they feel a little bit better, that's hugely empowering for them. It gives them an opportunity to have a bit more optimism on their life and go, oh, okay, I feel a bit better in myself now. So now I'm probably more likely to do some exercise and I'm probably more likely to be motivated to eat better. And I'm more capable and able and more motivated to do these other things that Bo or Shaun, whoever's telling me that I should do as well, that seem less important to me when I'm in pain. And now when I'm out of pain, I can kind of go, well, if I actually believe what they're saying and the rapport is good, then I'll take that advice as well. And then guess what? They don't need to see us as often. Then they have their own strategy. They have self-efficacy, that thing we always go on about that manual therapy apparently takes away from patients. And it will if all you do is perpetuate this idea that our patients need us to fix them on a regular basis. That is an incorrect, false, and damaging narrative for us to perpetuate with our patients. And yeah, we can't emphasize that enough, I don't think.
Yeah, and it's all about an integrated approach to care, like we shouldn't be using just one specific modality. If we say manual therapy, it's not about just doing manual therapy. Like there's a consultation, there's that therapeutic alliance, building rapport, gaining their trust, educating them, understanding their story, hearing their story, and really validating them that is important. But then really spending the time on that. So then you can shift that focus to, okay, well, what's next? Where do we go from here? What do you think the best approach is? And how do you think that we could get there? How could we help you to remove some of these barriers going forward? And, that's sort of acknowledging the patient, but saying, okay, I really understand that. And I really understand how impactful that has been on your life. But let's focus on moving forward in the next steps and where we've got to go from here, because that can be empowering. All right. And so from there on, we shouldn't be then focusing on what their report says, what their these diagnostic labels are, and direct shifting that attention away from them, acknowledging it, but shifting that attention away and moving towards this goal-directed behavior and really understanding the person. And I think with manual therapy, we can use that really well as a part of the overall treatment plan. And as time goes on, you become much more of a coach and giving them guidance and instructions and showing them that there is some progression. And I think that that's really important to give them that support. A lot of people that come in with persistent pain, they may not have a very good support network, and that clinician, whoever you are, whatever you do, can be a really important support network for that person to be able just to listen to them. And we don't need to be jamming more diagnostic labels down their throat and focusing on the structure and all of this damage, because that can influence their internal model. That influences how they perceive the world. All right. And when there's this mismatch between their internal model and the actual sensory input, they put more weight on that internal model and that they need more protection. All right. And that's a processing error. It's not necessarily a structural damage problem. It's an error in the way that they're perceiving the world, because there's a lot more weight placed on their beliefs and the emotions that go with that, and that they need to be in this hyper vigilant protection state. And so in the context of manual therapy, we're aiming to shift that balance. So there's more trust in their body. There's more reliance on the actual sensory information, and not this, I guess, inaccurate prediction from their internal model.
Yeah, good. And look, it's interesting, isn't it? And the word we talk about, the words and the language that our patients will use, and us trying to pick up on the details within that and adjust. I think it's probably a good exercise as a practitioner to put yourself in the position of a patient occasionally and listen to how you talk as well, so you can understand it from both sides. I did this week. In fact, I've had some. I'm going to use the correct language. I've had a sensitive low back now for a little while, then it comes and goes, and so I wanted to get some fresh eyes on it. So I went through the exercise, knowing that I would go in there with my own biases, my own beliefs, my own understanding of what I think is going on, and I tried to intentionally use this idea as the patient. And I sat down with an osteopath, and he started to ask me questions, and he said, "What?" He asked a great question, which is, "What would you like to get out of today's session?" And I stopped and thought about that for a second. And I was in a degree of discomfort on that given day. But I remembered that I was going there because I wanted a new opinion. I said, I'd like to get some fresh eyes on this. I want a new opinion. I want to expand my understanding of what I think is going on and maybe have someone correct me and take me in a different direction. That's what I'm looking for. And he kind of looked at me weird, like no one's ever said that to him before, but that's really what I wanted. And so by going through that process as a patient, I realized how important that language was. Now, doing it from both sides is important. So next time you're with a patient, you can kind of go, what questions should I ask to challenge the patient to really pull out their beliefs and understandings and their intentions and wants for being there on that day, and then you can work in that therapeutic alliance. And as we went through the process, he was saying, okay, when you do this movement, what happens there? And I'd say, well, I get this sense of it being stretched, but I don't know what it is. And I was being very careful about the language. And again, he was looking at me funny, like I'm used to people just saying, oh, it's tight or it's jammed or it's stuck, these sort of definitive terminology. I was trying very hard not to do that. It takes practice, right? And so when a patient says to you, I turn to the left and it's jammed, you could say to them, expand on that for me. What's the sensation like? And so rather than having them stuck on a term, a diagnostic term, you can say, what does it feel like? And just keep playing with this idea of sensation rather than fact, because what they feel may not be true. And we hear this all the time. People say, you put a needle into somebody and they say, oh, that's really sharp. And you go, describe it for me. Oh, it's this sort of heavy, achy sensation. You're like, oh, hang on a second. Those two things are kind of contradictory. Sharp and dull or heavy are two different terms, but patients' language, they don't have great vocabulary, to your point. They don't have great vocabulary or what's the word I'm looking for? It's just the accuracy in the vocabulary is often incorrect or not very specific. And so if we just take everybody's first word, first descriptive term on face value, it can take us as a practitioner in a completely different direction. So teasing out what do you mean, more details, often allows us to get a clearer picture. And then as the practitioner, once we've got we've asked all the questions we can, and we've got as clear a picture as we can, then we've got the opportunity to reframe it for them, and take them in a different, more hopeful, optimistic direction. And that's pretty empowering. I've certainly experienced this with patients over the years. The longer I've been in clinical practice, the less time I spent with hands-on bodies. And I'm a massive advocate for manual therapy. I think it is fantastic. But I've found myself doing less and less and less of it over time, and more of the talking, explaining, expanding, exploring, the curiosity in the conversation. And to my surprise, the patients are very happy, if not more happy with that, than just jumping on the table for the full however long and having me poke and prod them for that time. There'll be, you'll have patients that you will have taught that that's what they expect, and they come in expecting that, and that's because you've set them up for that. Like, that's the story, the narrative you've created for them. And so it is possible to change that and give you a bit of hope for anyone that's like, well, I've been doing it this way for 25 years. I can't change to this different way of doing it now because my patients expect it from me. 5%, 8%, 12% at a time, you can make these small adjustments and watch what happens with your patients, and see them start to kind of open up a bit more, give you different details and other information, and see opportunity rather than just a linear progression.
Yeah, I like that point, Shaun. And to give you an example of what that might look like as well, like if you are using your language, you could be priming people subconsciously to the experience or the expectation of pain. So if you said to a patient, I want you to bend forward and tell me when that sharp pain comes on. When they bend forward, they're already expecting that sharp pain to come on. All right. And so that's a subconscious prediction, and they're going to match that with their expectation. All right. And so the same sort of thing, if you like, it gives you an idea that you can influence someone's emotions just by the things that you can say. And I'll give you another example of this. It being pain that's embodied, and we can't just sort of separate those the mind from the body. So if I said to you, and I really want you to do this because I think it's useful, if I said to you, look really sad, look like you are really sad, or even think of something sad. Now think of something really happy, really good experience. And so you can see, even and they've demonstrated this on fMRI, that it changes in brain activation, but even thinking negative thoughts influences your body language. It can influence changes in neurobiology. Thinking happy thoughts can do the opposite. And it sort of goes back to this pessimistic attitudes as well. The more that we are in this negative mindset, it creates this internal model that the world is dangerous, and we're expecting something dangerous to happen. And when it does, it matches our expectations, and that becomes this sort of feed forward learned behavior. And so to disrupt that expectation from the prediction, we're looking to create more optimistic attitudes and focus on the positive effects that go with that. And so in a clinical context, bend forward, go to the point where you feel most comfortable, shifting that language. But also at the same time, if a patient does say that gets to a point of pain or discomfort, you might say something like, well, let's explore that. What else are you noticing? So rather than when they go forward and they feel that sharp pain, okay, do you feel safe in that position? If you feel safe there, can we explore some other feelings that you might be having? And that might bring on some emotional aspects to it as well. I do feel a little bit worried. I'm worried that when I come up, it might get worse. And so you might get them to a point of safety, and start to challenge their beliefs and their expectations, and get them to explore movements in different ways. And so that's sort of a practical example about how you could shift your language a little bit, but also allow the patient to be more comfortable and feel a little bit safer in that environment. And then change the context, get them to explore it, and show that it might be a little bit sensitive, but if you're okay to sit with that for a little bit, let's just see if that starts to change that level of sensitivity. All right. And so it's just also showing the patient that if they do have the onset of symptoms, to not panic, and that it's not necessarily indicating that it's making it worse or that there's more tissue damage. It could be just an overly sensitive alarm, like you mentioned before, Shaun. And so one way to de-threaten that is just to sort of gradually expose them to that in short doses over time, so they get more comfortable with that exposure, that it's not actually as dangerous as they once perceived it to be. And so that's where this update of this internal model can come into it. So update of their perception and update of these subconscious predictions to align more specifically with the actual incoming sensory information. And that's how we can start to change and influence a person's pain more positively.
Yeah, good. And look, I'm very conscious of the fact that some people might be listening to this without really getting the key point here and thinking about it from a point of view of, well, what if there's a fractured vertebra in the spine? Or what if there's a space occupying lesion or something really dangerous? Or what if there's a, you know, something that is actually structural that could potentially result in a real serious injury if a person was to go through into a position like vertebral artery dissection or something like that in certain movements, like if there's an actual threat present. Now, of course, we have to rule out. This is why we do assessment, why we have red flags, why we look for all of those things. What we're talking about here is cases where there's no obvious or apparent physical threat to a person's movement. And to your example of bending forward is a perfect one. And it brought up in my mind an analogy that I've used with patients sometimes of like the fear of heights. You know, you could have someone who is pathologically afraid of heights and they would walk onto the top of a mountain and there's a lookout over there with a rail to protect them from falling off. But the mere sight of that rail 20, 30 meters away has them in a cold sweat and their heart's racing and their body's shaking. Now, there's no physical threat to them. There's no real threat to them. This is a perceived threat. And now if you got that person to look at that every day, each day they'd get to that 30-meter mark and kind of go, okay, I'm still feeling really crappy here. This is no good. And they come back the next day and they eventually start to feel a little bit better. If you expose them to the fear, the threat, the apprehension, but make them feel safe and know that they don't have to go any further and then they can experience and play there and be comfortable and know that there's going to be no pressure on them. What happens is their body starts to realize that the threat is not as extreme or real as they once thought, and the sweats and the shaking and the fear will start to dissipate. And then the next day they go to 25 meters, and then it might be 20 meters, and then they realize that they can, you know, they can walk up quite happily to 10 meters and even look over the edge a little bit and know that, okay, I don't have to go any further. I'm okay. I'm safe. This is okay. This is okay. This is okay. And eventually, one day, they're going to walk up to that rail and know that the rail is strong and it can protect them. And there's no fear of them. There's no real threat of them going over the edge. And this is the opportunity that we have with manual therapy is we can give the person an opportunity to feel a little bit better, feel safe in a position, in a movement, experience that comfort and that certainty or a degree of certainty, and just nudge that apprehension, that fear, or that misheld belief a little bit further until eventually they get to the point that is physically appropriate, that we should all be able to get to and feel comfortable there. And it's when somebody has an incident like, oh, they fell out of a tree, or they, you know, there was a height related incident, they might go, well, I go back again. And that's perfectly normal. That's understandable. And you go, okay, well, how do we get back? How do we get you back to where you were? We give you this gentle exposure with feelings of safety, feelings of certainty, feeling of comfort. This is the power of the practitioner who can change that narrative for the patient, is to hold their hand, walk with them, help them feel safe along the way, build the confidence, and then teach them that they are okay. That's the trick. That is the trick, I think, with this changing of narrative.
Yeah, I really like that analogy. That's great.
Mm. How do we sum this up, Bo? Because I think there's a lot to unpack within this, but there's probably some key takeaways. Give us yours.
Yeah, I think, you know, having a bit of a discussion with your patient at the end and just saying, so what do you think the next steps are, and what do you really think's going on? Like, how would you say that back to me? So that when they walk away, it's not embedded in this negative or pessimistic mindset. And that's not always easy to change in the first session, so that might take a little bit of time. But just acknowledging different contributors, I think that's important to bring their attention to the other potential contributors that could influence their overall experience of pain. So that's important. So it's not just one that they focus on, the structure, the disc, the scan, whatever that may be. Um, Give them some strategies to help to overcome that, whether that be movement, whether that be some stress relief, whether that be some environmental modifications, some lifestyle modifications. It could be that you're also going to collaborate with other practitioners, like someone like a naturopath or a psychologist or an exercise professional. So looking at this from a broader lens as opposed to this narrow structural, specific focus. So broadening that lens a little bit. Um, but yeah, really validating the patient, shifting that attention away from the structure and more towards the future, and using some goal setting strategies, because this does take time, and it's not something that is up to the clinician solely to fix. It's really about engaging the patient in this process, and using things like changes in attention, mindfulness, changes in their beliefs, getting them to rewrite that narrative so it's not that structure isn't tied to who they are, like I mentioned with Bill at the start. So
Mm.
sort of shifting away from that. But yeah, and then I guess sort of really reframing, what it means to them, and giving them some positivity about their body, and the how adaptable we are as human beings.
Yeah, brilliant. That's it. And also remembering, so I'll just add one extra point, which is also remembering that as a clinician, it's not one or the other approach. It's like what we're talking about here is essentially pain science education, using language to help somebody with their presentation. And you might think, well, it seems like the whole world is just going towards this pain science education thing. Well, yeah, because it works, but it's not that instead of manual therapy, or that instead of exercise, or that instead of seeing a psychologist. It's that and those things. And so this is the rocket fuel that we pour into the engine. Like if you want to give somebody results, you can do just about any kind of clinical intervention with them, they'll get results. But when you start to add other ingredients, we see better results. We see this with dry needling, right? We know that dry needling is fantastic for reducing people's pain. But when you combine it with other interventions, even better. So the rocket fuel is the combination of the multiple things that all contribute to the person's improvement or movement forward, because there are multiple things contributing to the fact that got the thing that got them there. They didn't twist their back and suddenly had chronic pain for 30 years. There's other things, right? And so there's no one solution. It is about providing multiple facets in different approaches, inputs into the patient's body that can be through the ears, through their eyes, through their skin. All of these different things are ways that the human body perceives the world. And if we don't utilize them all, we're probably not doing them the best service that we possibly can.
Yeah, that's right. You can't just pull out one aspect of this. When pain is persistent, it becomes comorbid. You see this a lot. There's a strong association between pain, anxiety, and anxiety is often comorbid with depression. And when someone's in persistent pain, it can be a little bit of a vicious cycle that goes on there. And so just then focusing on, well, let's treat this trigger point and pull out the muscular component of this, well, that's unlikely to make long-term changes, because by that time there are numerous changes in their entire system. And so it's, yeah, again, just addressing that person as a whole. It's the person that has pain, and it's not the structure specifically.
Absolutely. It's the person with their pain and the story they've put around that and the narrative they put around it. Beautiful. Excellent. All right, Bo, let's wrap it up there. Thank you, everyone, for tuning in. Welcome back for 2025, and we'll see you on the next episode.